Good evening, all. Welcome to the case of the month. 8-year male child came with complaints of low-grade fever and altered sensorium, throbbing headache in hospital region since 4 days, 2 episodes of vomiting, 4 episodes of seizures 5 days back, history of antibiotic usage suspecting encephalitis, previous history of gastroenteritis, burning micturition associated with mild swelling of face and limbs 1 month back. There is no history of drug abuse, usage of steroids, chemotherapeutics, cytotoxic agents, immunosuppressants, or modulators, no history of autoimmune disease, connective tissue disease, sickle cell disease, or no history of recent blood transfusion. These are the investigations. With all, there is no significant titers. Dengue and scrub typhus are negative. MP is negative. CRP is negative. Even CVP, there is mild raised WBC. Serum glucose and electrolytes are normal. Serum complement C3 is mild reduced. Anti-DNase is positive, elevated, and ANA profile is completely negative. And there are occasional high BP recordings of 130 to 40 by 90. And the patient was referred to radiology department in, in view of history of fever, altered sensorium, vomitings, and seizures. So it was suspected as a case of encephalitis and sent to radiology department. You can see there is edema in the perioccipital lobes, even in the left suprafrontal lobe, which is depicted by these red arrows, and even on flare there is hyperintense areas in the perioccipital lobes, and even in the left suprafrontal lobe. There is no restricted diffusion on DWI, and ADC, there are high ADC values, suggestive of vasogenic edema in the perioccipital lobes, predominantly in the perioccipital lobes. And there is no blooming on GRE, suggestive of there is no hemorrhage, no significant enhancement on post-contrast images. These are the coronal images. You can see edema is clearly seen in the perioccipital lobes. And angiogram is completely normal, no abrupt cutoff or no narrowing or non-visualization to suggest as atherosclerotic narrowing or thrombosis, no beading or knotting or dilatations in the visualized arteries, no significant compression narrowing in the posterior circulation. There is no filling defects in the venogram to suggest it as cerebral venous thrombosis. And the follow-up scan was taken after 1 week. This is the initial scan and this is the follow-up scan. You can clearly see this is the vasogenic edema in the perioccipital lobes on T2 and flare, which is completely resolved in the follow-up scan. That is, after 1 week, the vasogenic edema was resolved in the follow-up scans. This is the coronal images. You can see this is the vasogenic edema in the perioccipital lobes. It has completely resolved. Only minimal edema is seen in the perioccipital lobes. And ultrasound abdomen was taken in view of history of burning micturition. There is raised ecotexture of bilateral kidneys, mild raised vascularity and color Doppler. There is minimal bladder wall thickening. So what are the differential diagnoses we can consider in this case are infectious encephalitis, as the patient has fever, altered sensorium, but there is no restricted diffusion, no cytotoxic edema, and no involvement of brainstem and cerebellum. So infectious encephalitis was less likely. Angiogram, there is no beading or strings of bead appearance on angiogram. So there is reversible cerebral vasoconstriction or CNS vasculitis is ruled out. Serum glucose is normal, so serum severe hypoglycemia is also ruled out. Hypoxic ischemic encephalopathy, there is no history of hypoxia in the patient. And venogram was normal, there are no filling defects, so cerebral venous thrombosis is ruled out. There is no history of autoimmune disease. There is no history of malignancies or tumor. CNS vasculitis is also ruled out because the angiogram was normal. Electrolytes are normal, so osmotic demyelination syndrome is ruled out. No history of acute demyelinating encephalomyelitis, and there are no history of drug or toxins exposure to the patient, so metabolic and toxic leukoencephalopathy is less likely. So basing upon the features, there is child coming with the history of fever, altered sensorium, seizures, and vomitings with intermittent raised episodes of high blood pressures. So, and there is vasogenic edema in the perioccipital lobes, which is completely resolved in the follow-up scan within a week. So the diagnosis was suspected was press in child. So press in child is not common when compared with adults. So this is the case of press in child. So in the CT, we can see hypodensities in areas of edema, hyperdensities in area of hemorrhage. On MRI, T1, it is hypointense in the areas of edema. Flare and T2, it is hyperintense. Diffusion restriction is not commonly seen. ADC, there is high values. GRE may be show a blooming on GRE in case of hemorrhage. SWA may show microhemorrhages. And sometimes there is patchy variable enhancement or leptomeningeal enhancement. So what is the pathophysiology of PRES? That is post-reversible encephalopathy syndrome. Elevated arterial pressures leading to cerebral hyperperfusion, autoregulation overcome, leading to blood-brain barrier dysfunction or vascular leakage, leading to vasogenic edema. This is the theory 1. And theory 2 is cytotoxic injury, which leads to endothelial dysfunction, which leads to vasogenic edema. So what are the different radiological characteristics of PRES? One is holohemispheric watershed pattern, that is involves the watershed zones between ACA PCA or ACA MCA, and then vasogenic edema may be seen in frontal parietal and occipital lobes. Other one is dominant parietal occipital lobe pattern, which is commonly seen, that is posterior parts of parietal occipital lobes are involved. These parietal occipital lobes are commonly involved because there is less dense sympathetic nervous system innervation in the posterior circulation when compared with the anterior circulation. So this is the reason why parietal occipital lobes are commonly involved than the frontal lobes. And other pattern is superior frontal sulcus pattern. And fourth one is partial or asymmetrical expansion of primary pattern. This is the most common pattern. So in this also the affected regions are parietal occipital lobes. These are the 4 different radiological characteristic patterns of PRES. So what are the atypical MRI findings in PRES? You can see edema can also sometimes affect basal ganglia and brainstem and cerebellum. So, and cerebral herniation may be also seen if brainstem or cerebellum are involved. In this case, if the brainstem, basal ganglia, brainstem and cerebellum are not involved, so encephalitis was less likely. Restricted diffusion can be seen in MRI in 15 to 30% case of PRES. Ischemia or infarcts can also be seen. Enhancement is also seen in 20% of cases. Intracerebral hemorrhage can be also seen in PRES, that is in 10 to 25% of cases. In this, the 3 presentations are parenchymal hemorrhage, sulcal subarachnoid hemorrhage, or multiple microbleeds. If there is sulcal subarachnoid hemorrhage in the older child or adults, RCVS is the most common diagnosis we have to suspect, along with CNS vasculitis. So what is the mnemonic we have to remember in a PRES in child, which will cover all the pathophysiology or the etiological causes for the PRES, which has to be ruled out in case of a child. So that is PRES in child. P is post-SPGN, pheochromocytoma, primary aldosteronism or polyarteritis nodosa. R is renal disease, glomerulonephritis or nephrotic syndrome. E is erythropoietin or granulocyte stimulating factor. S is sickle cell disease, steroid therapy or SLE. I is intermittent porphyrias. N is narcotic or drug abuse, that is amphetamine or cocaine abuse, which is common in old children or adults. C is cytotoxic agents, chemotherapy or collagen vascular disease. H is hyperparathyroidism. I is immunosuppressive agents, immunomodulators, interferon alpha or IV immunoglobulins. L is linezolid or ciprofloxacin antibiotics. D is drug induced, that is all the chemotherapy, cyclosporin or cytotoxic agents. So what are the take-home message or carry-home message? That is, parietal occipital lobes are commonly involved due to less sympathetic innervation of the posterior circulation. PRES in child is not common but can be suspected due to clinico-radiological disproportion as seen in this case, which was because the case is initially suspected as a case of encephalitis, but because of lack of cytotoxic edema, lack of involvement of brainstem and cerebellum, and there is only vasogenic edema in the parietal occipital lobes, which is completely reversed in the follow-up scans with history of intermittent raised blood pressure findings. So we have suspected PRES rather than encephalitis or stroke or CSVT. PRES in child is commonly misdiagnosed as encephalitis, stroke, hypoglycemia or hypoxic ischemic injury. Follow up the case within week or 2 weeks. If you suspect PRES, follow up the case within week or 2 weeks because reversible findings or reversible vasogenic edema is characteristic or pathognomonic of PRES. And rule out renal disease, especially SPGN or lupus nephritis. In this case, it was a case of post-SPGN PRES. And lupus nephritis was ruled out because ANA profile was negative. There is rule out recent history of blood transfusion, high dose of steroids or drug abuse. Rule out irrational antibiotic usage in suspected case of encephalitis because ciprofloxacin-like antibiotics can also cause PRES. Rule out history of collagen vascular disease, autoimmune disease, sickle cell disease and SLE, which were not seen in this case. So these are the few references. Thank you all.